Good afternoon, and welcome to Exploring Opportunities to Enhance Operational Resilience during EHR Downtime, a health system CIO production, sponsored by Interlace Health. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the founder and editor-in-chief of healthsystemCIO, and I'll be your moderator. We're looking forward to your participation. You can send your questions or comments in at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time, first we're going to go about 35 minutes with our main panel discussion featuring Chris Akeroyd, CIO at Lee Health, Stuart James, VP and Chief Operations Officer and Deputy CIO with CHRISTUS Health, Allison Reichenbach, President and CEO with Interlace Health, and then we will have our Q&A. So without any further delay, let's jump right in. Chris, let's start with you. Can you give us an overview of your organization and your role?
Yeah, absolutely. Excited to be here. So good afternoon for me and morning for others. But Chris Akeroyd, I'm the Chief Information Officer for Lee Health. Actually joined here about 9 months ago and came from the Dallas area prior to that. But Lee Health, we're an integrated health system in Southwest Florida. So about a 5-hospital system, roughly 1,800 beds, primarily adult care with one pediatric facility. So my responsibility obviously includes all things technology, as I always say, but digital transformation, I would say, is probably one of our biggest focuses right now as we look at continuing margin pressure and things. But how do we transform and really take advantage of some of those capabilities that are out there? But excited to be here. So thank you, Anthony.
Excellent, Chris. Thank you. Stuart?
Hello, everyone. Stuart James. I am with CHRISTUS Health. We're a multinational health system headquartered in Dallas, Texas. We've got hospitals, clinics in Texas, New Mexico, Louisiana. Then we have operations in Mexico, Colombia, and Chile. As the deputy CIO, I've got a portfolio that includes applications, data, integrations, innovation, and overall service management and operations, the IS function. Been with them for about 6 years and looking forward to our conversation today.
All right, Stuart, thank you. Allison?
Yeah, thank you so much, Anthony. Allison Reichenbach. I'm the CEO of Interlace Health. I started my career in law, now a recovering attorney, and have spent the last 14 years or so working in healthcare. Interlace Health has spent more than 30 years solving complicated documentation challenges across health systems. And for today's purposes, one of the things that we've learned during that time is that downtime is fundamentally a documentation problem. So we end up doing a lot of work helping health systems prepare for and manage that effectively, and excited to chat on it today.
All right, thank you, Allison. All right, let's jump right in. Chris, we're going to start with you. How do you define operational resilience in the context of EHR downtime? And has your definition changed over the past few years, especially as health systems have become more dependent on their digital infrastructure?
Yeah, so it's such a good question, and I guess the kind of shortcut part of the answer, it certainly has changed quite a bit. I think the threats and the opportunities are out there are completely different. But when we look at operational resilience, one of the things I preach quite a bit is that this is more about an organization's response and our ability to continue to deliver care, and most importantly, safe care. And the challenge that we're faced with is this has to be done mostly naturally, without kind of hesitation by the caregivers in this. And so the problem, really, I would say, the transformation has become what used to be centered as a technology problem, and really my part of my role is to make sure that this is an organizational capability that we've developed and placed emphasis into. You hear this all the time, right? It says we've transitioned to more EMR, more electronic workflows, dependency on technologies, the education of our nurses, our physicians. It's taught with the technology. So we're seeing a current workforce that's never really done paper. And so when we're dealing with downtimes, short or even short, we kind of manage okay, right? But it's those extended that are the larger risk. Getting back into paper and in things of, you start having these conversations, but things of just bed boards of where are my patients become a conversation, and things we take for granted today that used to be so well oiled in our organizations are no longer kind of that capability.
Yeah, excellent, Chris. Quick follow-up there. This is just a different issue, so to speak, but I'd like just quickly your thoughts on it. You mentioned the concept that most clinicians are only being taught with electronic tools. Um, is there any thinking that is not the best paradigm and that medical schools should be teaching paper as well?
It's, I've never really thought it from that perspective. I've always kind of taken it as that's where we are, because that's just the curve of technology adoption. The challenge might be this is, I mean, it's fine that you're taught that in school, but if we don't continue the education in the workforce, you lose that ability. So if it happens during med school, fine. But I think it really kind of falls to our organizations to continue to figure out how we keep a level of capability there to balance that risk of an outage downtime.
Very good. Stuart, your thoughts?
I think Chris covered just about everything on this topic and did a great job with it. The definition, right, he nailed it. It's not just about being able to continue care, but safe care. Efficient care is a bonus, but safe care is a must. So that's your resilience, is you must be able to safely deliver care regardless of what's going on. And I don't think that definition has changed at all since we started this. What has changed is how difficult it is to survive without the technology based on the dependency. What's changed is exactly what Chris said, is people don't have the backup systems in place. They don't know how to use paper. They've never done some of those things. You've even seen some nurses now who don't know how to read prescriptions, right? Because all they've ever seen are electronic prescriptions. So it's a very, very different world. And in some ways, it reminds me of a moment in my life as I was growing up. Calculators were really a big thing. And my dad had a slide rule. And he insisted that I learn how to use it because, those old skills and those old tools seemed really important to him. And we spent several hours going over how to use the slide rule. And then I've never seen it again. Other than at one time, he taught me how to use it. So there's a balance there, right? How much time would you invest in teaching people about systems that they may never use, that they'll only use in emergency? So I think it comes down to not changing the way people are trained, to your point, but making sure that they understand the fundamentals so that if they have to work with a different tool set, and I'll define paper as a different tool set, that they have a basic understanding of what needs to be done. So focus more on what needs to be done than on the tool set you're using to get it done. Will make it easier for you to switch tool sets when you have to, just like if someone was trained and worked in a hospital where there's one EHR vendor and they go to another hospital, there's a different EHR vendor. Fundamentally, what they're doing is the same, just a different tool set.
Very good, Allison. What are your thoughts?
Yeah, I think we see this a lot where paper feels like a fallback, but I think more often than not, it actually just is a fragmentation event, right? The moment you go to paper, you're losing standardization, visibility, data integrity, and I think that's really where that risk starts to creep in. I think resilience meaning having a fallback process, usually paper to get through the outage used to work because things weren't as anchored to the EHR. The more interconnected we are, the more this disruption is spreading across the entire organization. So I do think, making sure that you can get through the outage itself is important, but really how well organizations are maintaining continuity and documentation and how cleanly they can recover afterwards seems to be something that most of the organizations that we work with are focusing a lot more on so that that disruption doesn't continue long after the system comes back online.
Excellent. Very good.
Anthony, just
Yeah.
just a quick comment. Allison mentioned an important point there. A lot of times during downtime, the problem is not the individual workflows, it's the interconnectivity between the workflows, right? Simple things that people take for granted, like they put a prescription in and it goes to the pharmacy. People don't necessarily associate that with, oh, it's replacing me calling the pharmacy. They're like, wait, what's supposed to happen now? Or they just flat don't even think about it because it happens automatically. So a lot of your risk is in those integrations of things that happen automatically that people either don't understand or don't think about because it's been happening automatically just all the time. So that's where a lot of your risk is in that integration layer.
Yeah, it's a great point, Stuart. And one of the dynamics I've been reading about a lot is how every health system wants those automatically triggered workflows to happen as much as possible, right? So we want a an input to cause a cascade of things to happen because that makes clinical practice better and easier. And that's the whole goal.
Right.
So, but that's exactly the problem when the systems go down, right? So
Yes.
it's interesting. Let me ask you a question. I'll start with you, Stuart. W- do you see it as the idea here is in terms of resilience, planning to move to paper if we lose our systems, or what I'm hearing more of now is planning to move to some sort of electronic backup system. Um, those are two different things, and you could possibly have both in mind, meaning you try and go to some sort of backup environment. There's an article on our site about what Centaur is doing with their isolated recovery cloud uh, dynamic they're creating. So they're specific that this specific model they're working on. So that's my question to you is how are you thinking about resilience in terms of, are you thinking about, having some sort of electronic resilience to another dynamic or system and then paper, or are you just thinking paper? Like, what's your latest thinking?
The answer is yes, all of the above, right? You have layers, and so you want to have fallback and say and failover so that you can always be on ideally fully operational equivalent of your system you're on, or some slightly degraded capability because you're in an IRE or something
That's
else.
it. That's exactly it. IRA.
But
Yep.
you cannot lose sight of the fact that sometimes all you have are your people. You don't have your systems, especially in the age of cyber, right? The idea is to your systems are going to be gone, or you don't know if your systems are safe to use, so you have to make a decision to stop using them. So while we do everything in our power to get to zero downtime, and we have layers of availability, we still have an obligation to plan for the absolute worst case scenario, which is that you're down. And we think about IT systems going down and everything else being normal. That's one scenario. Another scenario could be your physical space is damaged, right? You've had a fire, you've had a natural disaster of some sort. You're in a parking lot, intense, caring for a patient. The care must go on, and you have to do these things. These are extreme circumstances, and we don't see them often, which is what makes them so difficult to prepare for. So your mindset has to always include that worst case scenario of how do I do this without the systems. Chris and I and our teams will spend our entire life trying to make sure that the systems are always there, or if something happens to them, we can get them back quickly. That's our job. But on the clinical side, their job is to care for patients safely under any circumstance, right? So it's our job to make sure that they don't end up in that circumstance where the tools they depend on are not there. But we still have to have that mindset where we say, we have to plan for the eventuality. You just must plan for it. Hope you never need it, but you must plan for it.
That's a really, really great point. Um, I'll just go around the horn and let you guys react to that. Chris?
I, yeah, Stuart nails it right. You plan for the worst, hope for the best. Um, the complexity comes in this, and Stuart mentioned it earlier, of our architectures of workflow are so complex. And so more than just the EMR is kind of, so do you have an IRE around your EMR? Absolutely, that should be kind of table stakes at this point. But it's those workflow complexities, I think, that really kind of get more difficult for us in our roles in the current state, because I don't have a complete mirror copy of my entire environment outside that could withstand a cyber event. So, Stuart's example of prescriptions, and I've experienced this before, where the clearinghouses are down, or we're not able to connect to SureScripts or whatever, and prescribing of controlled substances becomes an issue. And so it's like, do we even have the right paper to write on to get it released from the pharmacy? And do your state regulations allow for it? And but those are such small parts of the workflow that you've got to pull those out before it happens, so we know where at least some of the friction is going to come up. I don't know if we can predict everything, but practicing that resilience of how we're going to work through complications like that is going to be key.
Allison?
Yeah, I think that's right, Chris. And I certainly agree with what you're saying, Stuart, around people really being everything in a downtime event. But I think what we consistently see is that the real differentiator in those type of events isn't just having great people, but it's whether those people are supported by really clear processes and structured tools. Because, in those high pressure moments, even the best teams can't rely on memory alone. You need those guardrails. Downtime is not the time to improvise, right? It's when standardization matters the most. And that's when, we've seen in our business, if I, put on my vendor hat for a moment, where structured e-forms really help. They guide teams through the right steps, ensure required information is captured, and make it much easier to bring everything back into the medical record afterward. So people are absolutely the foundation, but the process and structured documentation, I think, are what make the performance really consistent and safe. What is it that Mike Tyson says? Everyone's got a plan until they get punched in the face. You've got to you've got to have that consistent and safe plan in place.
Allison, when you're working with your customers and prospects, are you dealing with mostly CIOs? Are you dealing ever with emergency management? Are they ever brought into the conversations? Because that's obviously a key constituency for this not to be a technology problem in and of itself. It's an operational continuity problem, and emergency management is often going to have to be a partner in that.
Yeah, absolutely. And that's also the ED is where they often see the brunt of this, right? Because people are now waiting for hours and hours and hours. Maybe they're walking out the door. You're starting to lose revenue. And, it's also a spot where identification is going to be a real issue too. Making sure that all of that documentation is in place for somebody who's just walking in without an appointment, because we need to make sure that that documentation is intact further down the line. So we're talking with people at patient access, in the ED, clinical documentation, HIM managers, billing, compliance. It really touches everything. We've talked about this, and Chris, you touched on it as well, that IT plays a really critical role in restoring the systems, but they don't own a lot of what happens outside of that downtime. And so having the ED involved, HIM, clinical teams, rev cycle, they're the ones that are having to reconcile a lot of what happens later on down the line. And that's where that real operational burden shows up. So we're seeing more and more people coming to the table when we have those conversations. I think not to sort of sidetrack too much, but when we think about the scope of impact, going back to what we were talking about consolidating technology in the health system. And to be clear, I think consolidation really is the right move. It's reducing complexity, it's improving data consistency, it's making systems easier to manage, but it also concentrates that risk, right? So everything is running through one platform. Downtime stops being sort of this localized issue, and you need everybody at the table now because it's an enterprise-wide event.
Let's go around the horn and get any reactions to that. Stuart, any thoughts on what Allison just said?
I think Allison really nailed a lot of the key components of this, and how you function during the downtime is key. It is the responsibility of operations. And I want to say it in the context of it's like safety, right? It's everyone's responsibility, but they're still primary roles. And what we need to understand, because often people see this as an IT responsibility, the responsibility of IT is recovery, right? Disaster recovery, getting the systems back online. The primary responsibility of operations is business continuity. How do we continue to provide care? Allison mentioned the folks in the ED or the folks who might be coming into the ED, right? We worry about the people who were on the operating table in the middle of a surgery when that issue went down. So you have to think about everything. And as you think about resiliency, you just look at the environment we're in right now with major vendors being taken offline and the dependency we have on them, right? What do you do when you can't order supplies? All of your systems are up and fully functional. You can't order supplies. What do you do when the internet infrastructure in a large part of the entire country goes offline? Your systems are fine, but you can't communicate, right? You might not be able to get to your IRE because even though you've got multi-carrier redundancy, there's now an event that has impacted all of the major carriers. Not one, not two, but all of them. So the environment we're in says that more than ever, you've got to be mindful of how do I operate when the really bad thing happens. And don't think we have done everything we can, so this is not likely to happen. That is true, but it is still possible. And the other thing I would say is having the plan is just the beginning. Rehearsing the plan and practicing the plan is the key. If the plan is there on paper and nobody knows it or nobody knows what to do, you're going to have a problem. In the military and boot camp, they used to say, "We don't pay you to think." And I used to think that is a ridiculous thing to say. But what they meant in context is it's about training so that your instincts kick in when something bad happens. And I've used that example, and I'll wrap this up quickly. There's an old video of a guy who got sucked into the engine of a jet on an aircraft carrier, and he lived. The reason he lived is because everybody just did what they were trained to do when that happened. Right? That's not something that happens every day. So there's a guy standing at the front of the plane. As soon as he saw the guy get sucked in, he froze and put his hands above his head in a triangle. As soon as he did that, the pilot shut the engine off. And guys rushed towards the jet and got him out. And he literally got sucked into a turbine engine and lived because people didn't think. They just automatically did what they were trained to do. So if we don't train, we never get to that level.
Excellent. Chris?
Yeah, it's Stuart, you touched on something that I like a lot, which is kind of that third party, and I even just call it fourth party risk of things that are even outside our four walls that just further complicate what we're dealing with, and it the training and the relying on people and it's not being an IT problem. I couldn't agree more. The challenge is that technology or the IT departments know more about the connectivity of the processes and whether it be clinical or business than anybody else in the organization. We understand how that ED visit gets documented, but also turned into billing and coding, which gets us paid, which then pays payroll. And oh, by the way, here's how the time cards come across so that we can have payroll, and how we're paying our vendors. The whole ecosystem, right? We have a very unique vantage point from where we sit. The risk we run as leaders in this space is if we're not having that risk-based conversation, that leadership-based conversation of who all needs to be around the table and who all is responsible for this. I think that's an opportunity we've got to close quickly, because it too often just becomes a default of IT's got it figured out. And on small downtimes, we see this, right? Of if let's just say your Citrix environment's out, people can't get into Epic. Well, they're asking IT, and IT is usually responding like, "What do we do?" Well, you need to go to downtime. Lab, you need to be doing this, and physicians need to be doing that, and we're usually shepherding those conversations, and it's easy to do. We know what to do most of the time. We're not making necessarily the clinical calls, but so to kind of build on Allison's point, Stuart's both, we got to really reinforce who's the ownership of this and really help educate and drive those conversations.
Anthony, Chris brings up another excellent point that we live with all the time is during the downtime, right? Our role switches. Well, we're always trusted advisor, but that's a key part. We can't make the decisions, but we need to provide the clarity that allows the decision to be made. It's not unusual when we have, right? When the system is hard down, that's a lot easier. When an interface is down or when it's partially up, right? We'll usually get the question, well, should we go and divert? Meaning we send our patients somewhere else because we can't.
Yes.
We can't make that call. But what we can do is say, here's what we know. These two systems are not talking to each other based on our assessment. We think it's going to be at least 4 hours before they're back up, right? Best guess. It might be 2, it might be 6. We're going to give you the best information we have. And then somebody else needs to decide, is it safe to provide care or go and divert? Or we can say, this is where the disconnect is. You will not be able to print checks the way you normally do. Having that information, somebody operations then decides, okay, what do I do if I can't print checks, right? It's my job to make it clear to you that your ability to print checks is gone and we don't know when it'll be back. But I don't then have the answer, well, what do I do if I can't print checks? How do I pay people? That's where the operations have got to be ready to say, once we have clarity, we make the operational decisions. And it's the IT team's job to provide that clarity.
And go ahead, Allison, please.
I was just going to say, I completely agree with both what Stuart and Chris are saying. And it's been interesting from our perspective because the easiest way to get all of those folks buy-in is to have a significant downtime event. And then all of a sudden, all those people are showing up at the table and it's not just an IT issue anymore. We see that a lot. And I'm sure Stuart and Chris can probably appreciate that as well.
Yeah, and Stuart, the dynamic that you just described is it's made sense to me for a couple of years as I've been exploring this topic and having conversations with people. And that's always the discussion dynamic that I've gotten to in my mind and tried to explore with people is the interconnectedness of those relationships and how you need real time back and forth between clinicians and IT folks, and you could even have the FBI involved. You could have your cyber insurance company involved. You could have your CEO involved, your chief legal counsel, emergency management, and making it, or at least gathering all the information that would be needed by the decision maker, which I assume would be the CEO, perhaps, depending on the exact decision. That discussion, understanding the dynamics of that discussion and practicing it in a tabletop type environment, to me, that's really, really a compelling concept that if you haven't gotten there, when you do get there in real time, you're not going to be ready to get all the seats at the table to make the discussion in a timely manner. Does that make sense?
Absolutely.
Mind-blowing stuff. So, Chris, half of this is just getting your mind around these dynamics and then trying to move the organization forward to practice some of this stuff. Like you get it in your head, okay, this is kind of different scenarios. And scenario planning is really interesting as well. Stuart, you touched on the idea of scenario planning. You touched on regions of the country being out. We can go to a point where you have, some global catastrophe. You can't plan for that. Like we can't worry about that. It's a 1 in a billion, right? But we do have to come up with scenarios that we do want to plan for. But at some point, you have to say, you know what? If this happens, no one's coming to work because civilization has fallen apart. So we're not really worried about it, although maybe we are as a hospital. But so a couple issues there. Chris, let me let you jump in first anywhere you want.
I agree, but I think from a planning standpoint, where I've always kind of taken this is from a worst case scenario. And yes, you're right. It usually does not manifest that way. Which I guess in some ways, as you've gone through tabletops and done some of this planning, the participants and the operators, when it does come time, like, oh, this wasn't as bad as you said it was going to be. So that is good. But Allison, you make a solid point that in my past, to get everybody around the table, it took an event. It took us going through something that shook everybody up. And we've talked a lot here about resiliency and really around clinical. We can't forget that there's a business operation that runs behind it. And so patient safety is paramount, but things such as what the UKG outage taught us a couple years ago is that bad things can happen in your back office that could have very negative impacts on the front side, your ability to deliver safe care. And so I think that's part of what we got to keep in mind here too, is are we putting enough focus in other areas such as accounting, finance, payroll, and supply chain throughout our resiliency planning.
Very good, Stuart. Anything you want to jump in there with?
Piggybacking on the things that Chris said in the context of your question, I think it's important to have some simple sophistication, if I could use that oxymoron, in your planning. You're right. We can't plan for every eventuality, every scenario, but we can plan for the impact that is common to all of those things. And the worst case impact is I have to manually provide care, right? The worst case impact is I can't order supplies the way I normally do. There could be dozens of reasons that cause that, but the impact to you is the same. So I think you have to keep that in context as you're planning, because sometimes we get lost in the what ifs of the scenarios that caused it. And just for your resiliency, it's less about the cause than it is about the impact. So there are dozens of ways that you could lose your ability to speak to a pharmacy or something else. But it comes down to one question: what do I do if I can't electronically speak to the pharmacy? Tabletop exercises are important. They're great. We do them. But I remember a time years ago, and we don't do this anymore, I don't know many people do, we actually did real drills, right? Back then we had a hot site that I was in North Carolina, the hot site was in Pennsylvania. And the plan was we get on a plane and we fly to Pennsylvania and we recover the systems in 48 hours. And then 9/11 happened and all the aircraft were grounded.
Wow. Yep.
We never contemplated a time when we couldn't fly.
Right.
Right. So we redid our plans. And we didn't tell the teams when our drills were. My teams did not know. I knew, one or two other people knew, nobody else did. And the next time we did a drill after 9/11, we said, you can't fly. How do you get there? And that meant that they had to get on the phone, book tickets, all right, on a bus or rent a car or do something. They ended up renting a car. But it wasn't just a tabletop exercise. We figured out, where did you rent a car from? How long did it take you to drive? We actually had them drive through Philadelphia. Right? We scenario that's expensive, and we don't want to do that often. But maybe every 5 years you do something like that, or after a big event. And what we ended up doing is we moved our recovery center to some place that was within a 3-hour drive. Right? That was one of the requirements. It was far enough away that you had some geographic separation. But with what we learned about the new reality is that you might be a long way away and your 48-hour recovery time is now going to get expanded by 9 to 12 hours because you have to drive to your recovery center, because the other one was in Denver. So we didn't have any good options. We need to have one option that was within a reasonable drive. So that's just an example of where you learn from the events when they happen. And tabletop exercises are great and necessary, but occasionally you do the real simulation. You actually do what you would have to do if it was down.
That's great. That's great. And it is an interesting point, that compromise between the 3-hour. We're gonna make it closer because we're playing games here, right? We're gonna make it closer because when we come up with the scenario where we can't fly, we realize that being more than 3 hours drive away was unpleasant. But now you've compromised yourself for a different scenario where being within 3 hours is too close because it's a regional event that took that out. So you play with it, and you just have to come up with scenarios that you're comfortable with.
And you have to find balance, and we had
Balance.
both, right? We had a 3 hour option, and we had the traditional. Because before that, and Chris might remember this, it used to be East Coast West Coast separation, right? The thought process was there's nothing that's going to impact both the East Coast and the West Coast, so you establish on both coasts, and you're great. Well, unless you can't fly between them.
Right. All right, great. Allison, let me bring you in here. I want to talk a little bit about the topic of reconciliation post, you know, you're working in your downtime procedures in either a paper or electronic environment. I've heard some conversations about this where there is some, and I guess it depends on what you have set up. There's some trepidation. There's a lack, there's a reluctance to fail over to these things. They don't want to because they're expensive, number one. And this is me gathering from these discussions that failing over to backup systems is an extremely big deal. It's not fun to do. It's expensive to do. It's extremely disruptive to do. And it's super scary to figure out how to recover from that and reconcile. And there's almost a tendency sometimes to want to wait. Like, let's just wait. And this was said, and, by people involved in this, which is fascinating to me, that and different organizations in the past have made the decision we're just going to wait for 24, 48 hours because it's less expensive than failing over and coming back and trying to reconstruct everything. I'd like your thoughts on that and to go around the horn because that could impact what you're actually doing. It could impact how you set things up. Your thoughts?
Yeah, I mean, I think that hesitation is understandable. And if I'm sort of thinking about what you're putting on the table correctly, I mean, there's that hesitation to go to a failover system versus maybe we're just going to say we're going to go to paper. That feels simple and familiar. But I mentioned it a little bit earlier, but I think that's actually, I don't think, I know that it's actually introducing more risk, not less. When you're staying on paper, you're fragmenting your system of record, you're creating variability in how information is captured, and that just makes your recovery exponentially harder. So I think failover to software, even in a limited or downtime mode, you're preserving structure, you're enforcing required fields, you're maintaining a level of continuity that paper just can't. And you're dramatically reducing the risk of data loss or errors when you reconcile everything back into the EHR. So, while I think not going to your failover system and just going to paper and grabbing your forms out of your cubbies might feel, sort of more, you know, simple in the moment. In reality, I think that software failover is what keeps your processes consistent. It keeps your data trustworthy and your team supported the most so that in that recovery period, you're not looking at locating documentation, scanning,
Mm-hmm.
indexing. It gets really messy really quickly. And I think getting comfortable with that failover software is key in all of that.
So that's a great point. It's setting it up so that you can fail over to software. Although again, this is sort of coming up with scenarios. You can come up with a scenario where that's not possible, right? Some sort of right, but uh, have a scenario where you can do that if it's like the scenario isn't so dramatic. There are scenarios you can come up with that are not so dramatic where you're offline with your major systems, but you can still fill over to software. That's what you're talking about. So obviously that's what we want to do. Step one, we fail over software. We keep things structured. We keep people working in electronic format. And if we can't do that, God forbid, then we got to go to paper. But step one should be fail over to software. That's what you're saying.
I think that's right. And I wouldn't say would be amazed, but I mean, we can go pretty far down the emergency scenario list, because we learned during COVID, for instance, they were doing check-ins in parking lots and they didn't have internet access. And so we were able to build the system so that you could do all of that offline and then reconcile when you were back online. So there's some ways around that now. If there's no electricity and everything has died, that
Right.
you're at where you're at. But I do think that organizations are amazed by sort of how far down that emergency or sort of critical level of downtime you can go and still be electronic.
Yeah, so that's what we want to do, Stuart, right? We want to keep them electronic as much as we can. If we think electronic systems keep everyone safer, which is the whole premise of modern medicine, We want to keep them electronic as long as we can. And that's what you said. It's IT's job to do our best to keep the systems up, to give you the best case scenario of working with the tools that are going to keep you in your usual workflow. And then, but again, it's on you, operations. If all that doesn't work out, it's on you to figure out how to continue to give care. Like that's on you. I'm going to do my best to make sure you're in the best position possible. But ultimately, you have to continue to figure out how you're going to continue to give care.
Yeah, just acknowledging that it's still always a partnership, right? You're still there as
Right.
a trusted advisor. There's still that shared
Right.
that collaboration, and acknowledging that there is value in having backup or redundant electronic processes. The key is to be intentional and have a plan for what you want to do. There are times when immediately failing over to a backup system is appropriate. And if that backup system is a mirror of your normal system, then that's easier. If that backup system is a completely different set of workflows and processes, right, you need to make sure people are trained on that before it's needed. And you do have to make decisions on when. We have procedures in every organization I've worked in that include a wait, right? If it's
Yes.
going to be 4 hours or less, if we reasonably believe it to, one of the options is to wait and wait it out, because the recovery process, the risk of people working in unfamiliar processes, the fact that your backup systems don't have all of the same integrations that you're used to can sometimes introduce in and of itself safety considerations, because things that people are used to happening that are just muscle memory for them don't happen. So that in and of itself represents a safety consideration. So the only thing I would add to the conversation is that it needs to be an intentional strategy and an intentional decision to execute that strategy, not an automatic, we fail over to something just as soon as one goes down. Think about it beforehand, understand the consequences, be intentional about it. But yes, absolutely, having lots of paper and chaos after a downtime is not a good thing. But you plan for it. And we do have, every place I've ever worked has had some contingency that says, here's the trigger point. And it's usually around 4 hours, right? If we reasonably believe it's going to be 4 hours or less, waiting is an acceptable option.
And Stuart, when we say waiting, what's happening during those 4 hours? Care is
Um,
continuing somehow, or is there some sort of diversion and minimal,
no,
operation?
care is continuing. People are documenting, making rounds, things that are non-critical that can wait. Like, for example, we don't start an elective surgery during that 4 hours, right? During that time. So there are care decisions being made, and anything that needs to be documented is being documented. It could be documented in a backup system, right? Many of our electronic systems, their EHRs have downtime workstations that are standalone that you can register patients in, that you can do some basic documentation in and sync it later, or you have a third party system. So care will continue. This is important. Care must always continue safely. Whether you're on paper, your main system, or a backup system, care must continue safely. But
Chris? Oh,
wait
go.
could
Sorry.
mean
Go ahead.
certain things may be deferred until after the outage.
Got it. Chris, this concept of a wait period, is this something you've got baked into your operation, like formally?
It is. It's I agree with it. There are complications with failover and coming back from a failover system when you talk about EMR things like that. But and so in situations where it's not a clean cut, absolutely, I think you need those. You need it well documented. It was even in policy procedure for us of when at what point is it required that we either activate a DR system or whatever. And there was even detail within those procedures on how to come back. So between certain periods of time, things will be manually re-entered if we were on paper, so that we're getting discrete data back in the system. So kind of thought process, but it should always be evolving, right? I think our main responsibility as leaders in this is in building on Allison's point of we should be architecting upfront solutions with resiliency in mind. And where we can make failover seamless, natural, and always occurring, and maybe an always on type of scenario or active, however you want to look at it, we should be doing that. And so as our capabilities continue to mature, I think our policies and procedures need to follow that. Just because we've always said we wait 4 hours before we do something doesn't mean it always has to be the case. We always need to reassess capability, reassess risk, and education training and such there. So I think it's an always moving target.
Allison, anything you want to add there?
Yeah, I think what I'm hearing both Stuart and Chris say, which I completely agree with, is wanting those workflows to be as close as possible to what it looks like in uptime. And for us, that's always the goal. I think the challenge when you wait is that the workflows don't end up staying the same in practice. So even with the best teams, people start adapting in real time, skipping steps, documenting differently, creating workarounds because the system that normally enforces those workflows isn't there. So we try to think of a failover system, not about introducing something new. And it sounds like you guys are both saying the same thing. It's about preserving your existing workflows as closely as possible under stress. So you're keeping the structure, the required fields, the sequencing intact. So your team isn't improvising. So I think in that instance, if you can get really close to that, then moving to failover sooner protects that workflow consistency. But you do have to have that closeness to your uptime workflows, which I think both of you sort of spoke to.
Allison,
Excellent. Go
I
ahead,
would
Stuart.
add a quick nuance, and Chris alluded to this. And this is a technical differentiation between a failover and a backup, right? A failover implies it's a mirror of your main system, right? Maybe a smaller server, it might only support 500 concurrent users versus 1,000, but and a failover is like automatic, right? The operators don't have to make a decision to failover. It's an IT configuration versus a backup, which is an alternative that you would make an intentional decision to say, we're going to use this backup system. So those nuances matter when we're having the conversations, but failover, we designed for that, and failover would, if it works, you don't have downtime.
Yeah, and the more we get resilient at like an active failover, mirrored databases, et cetera, there's still caution there, but data integrity is always kind of top in mind of how close in sync were we at the time of the event. Do we have a complete data set where we're moving over to? And then more importantly, how do we re-merge records when things come back? Because I certainly don't want to lose or corrupt data post-event.
Yeah, that's a huge issue. That's a whole webinar in and of itself, right? Coming back online and getting the data back into the production systems. Allison, do you have a question for one or both of your co-panelists?
I would love to hear from both of you if you've experienced, it sounds like both of you have experienced obviously downtime events in the past. What was something that you severely underestimated in terms of the depth of disruption or in terms of something that sort of wasn't part of your plan that you would maybe say to people listening, don't forget this.
Chris?
Well, I mentioned UKG earlier. I would say that one really kind of caught us flat-footed, and it wasn't just us. It was when Workforce Central was ransomed, if we recall that, and it happened at one of the worst times of the year it could, right before the holidays. We hadn't planned that scenario, and so we underestimated really what it would look like and take to just get payroll flowing. And we were living in a SaaS world where we had a lot of dependency on a third party to deliver, and there weren't a lot of options for us to pivot away or pivot toward. We were kind of dealt a situation that was really unrehearsed. You couldn't pull data from clocks. No mechanism internally to track time and then get it over to payroll for processing and et cetera, et cetera. So it really shined a light on inadequacies that we had in some of that planning. Like I said, I mentioned before, we can certainly keep a patient safe. We can avoid diversion in the ED, and we were really, really confident in all our clinical processes. Just we hadn't put enough business focus into some of the other parts.
Excellent. Stuart?
Yeah, like Chris, I would say it's some of the non-clinical impacts that you just don't think about. Another thing that I would add that I'd say we underestimate is just how little our teams know about the processes because so many things happen automatically. And this will usually manifest in the partial downtime, right? When an integration is down or one system is down, and you're trying to figure out, what to do, and you realize that nobody understands the process end to end because these things just happen back, right? Things happen in the background automatically. Now, for the major ones, we've got all the workflow mapped out, but there's always some little sub process that nobody understands that causes so much trouble during the downtime. And when you find those, document them and think what else might be similar and go looking for them.
Mm-hmm. Excellent point. Very good.
You
All right,
know,
go ahead.
I was just going to add on to Stuart's there because I think every time that we're in a downtime, right? It's always a unique scenario. It's never the same. And Stuart, kind of to your point there of some things are up, some things are down. This is different. We really had rehearsed that from an IT perspective, and we're always also trying to figure out, well, is this the time we pull the trigger or not pull the trigger? Do we move? Do we not move? And so I think that comes back to training internally. But it's always interesting to your point of we're dealt a new hand every time, and it's how well we're ready for that is always key.
I'll give one quick one. I know we're wrapping up. The other thing is, when do you make the decision to go down? Right? In those intermittent scenarios, you see that, 80% of your lab orders, your medication orders are crossing over. But you just can't figure out why that 20% or even 2% is not crossing over. At what point do you decide you need to know 100% of what your medication or lab orders are? And if you can't do that, even though your system is looking good, working good, and 98% of users are in, you say, we have to take this offline because we can't guarantee safety. We don't know that we're not missing an important order. So we're going to go to something that we know, which is you have to call all the orders in.
And not waiting. That's a really good point, Stuart. We run into so many organizations that are afraid to have a planned downtime because they're not confident in their systems. Their software, has these little hiccups like you're talking about. Maybe 20% is not doing what it wants to do, or they're so behind in versioning because they're not wanting to deal with an unplanned or with a planned downtime. So not the longer you wait, the sometimes the more it creates problems. We see that a lot. That's a really good point.
All right. We're just about out of time. So I'd like to get a final thought from everyone, final piece of advice, and we'll go around the horn. Chris, let's start with you.
Yeah, I mentioned it earlier, but I think it's resilience is really about the planning, the upfront planning, and I mentioned the architecture. It needs to really be a design consideration, an architecture consideration from the very beginning, and that includes operational attention. So as we're implementing new systems or changes to make major changes to systems, we got to keep in mind some of those operating capabilities of are we transitioning that well and thinking through that. So it's more than just technology delivery from an IT perspective, but it's a business risk conversation that needs to be occurring.
Excellent. Stuart?
Very similar perspective to Chris. It's about business risk. It's about the overall collaboration between IT and operations. Having a plan is important. Understand the plan is important. Practicing the plan is most important. All right. This is not an if, it's a when. It's not an if, it's a when. Be ready.
Excellent. Thank you, Stuart. Allison?
Yeah, I think I would just reiterate what I said at the start that downtime, from our perspective, is fundamentally a documentation problem. So when that EHR goes down, it's not just breaking your access to a system. It's the ability to create, to manage, and connect, as we talked about, the documentation across the organization. And making sure that that's happening in a structured way. So the organizations that we see that are handling downtime the best are definitely the ones that are maintaining control over that documentation during the outage. So not just worrying about the system access, but maintaining control. And I think that really what determines whether downtime is a short disruption or a really prolonged operational issue.
Excellent. Thank you, Allison. All right, we are about out of time. I want to thank everyone for attending. Regarding continuing education, you can use the final slide in this deck. You can get the on-demand recording when that's ready for viewing. You'll get an email about that. If you want to work with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. So with that, I want to thank our tremendous panel, Chris Akeroyd, Stuart James, and Allison Reichenbach. I want to thank Interlace Health for making the event possible and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you all.
Thank you all.